The first talk I'm going to give is current position of MGB. I have nothing to disclose. We'll start with name of this procedure. This is a new procedure. It's been done, the first one done 1997 by Dr. Robert Rutledge in the United States. And it has created a turbulence in the bariatric field. Lots of arguments against the procedures. So far, about 60,000 operations done. So the first conflict is about the name. Everybody is claiming the name of procedure. Rutledge named it mini gastric bypass. And then Carbajo from Spain, he named it one anastomosis gastric bypass. Professor Lee in Taiwan named it single anastomosis gastric bypass. And the original name of procedure by Professor Mason in Leuven, United States, he named it omega loop gastric bypass, and he has done the first one, not Rutledge version, in 1967. But the consensus at the moment is MGB and one anastomosis gastric bypass. Professor Mason, 1967, he did omega loop, and this is not, hasn't attended or taken by surgeons because of bile reflux. The major problem with this procedure is bile reflux. As you can see, he transected the stomach in the upper part, and he joined the bowel, small bowel, to the lateral side of the stomach. And he has used this procedure to treat patients, obese patients with peptic ulcer disease. And he reported in annal of surgery his results, which is good. The excess weight loss reaching about 35% of patients, but he had also a large number of complications. In 1997, Rutledge has introduced MGB with this configuration. Stabling of a stomach, long pouch is about 12 to 14 centimeters, and joining the small bowel to the distal part of the pouch, end to side anastomosis. And he used the biliopancreatic limb is about 200 centimeters. Professor Miguel Carbajo from Spain, he modified the procedure. And the main concern was the bile reflux. So he created anti-reflux mechanisms. And as you can see, he's creating about 8 to 9 centimeters of small bowel above the junction, the gastrojejunectomy, which is side-to-side anastomosis, not end-to-side anastomosis. We will talk about this next day to show what is the difference. After doing 2,500 operations, Dr. Rutledge concluded that MGB is continuing to provide good results, both for metabolic syndrome and weight reduction. So really good number of patients, and this is a very powerful study. And then the three eminent peoples who are leading the MGB clinical work are Professor Dietel. The one on the right is Canadian, and Rutledge is American, and Kular is Indian. MGB and one anastomosis club, international club, was born, and everybody of bariatric surgeon can join this club. This is their website. It's a very easy registration process. IFSO statement, International Federation of Obesity, this is on their website as well, you can see. So they accepted the procedure. This is the international large bodies supporting the bariatric and metabolic surgery. They recognize it as safe, simple, and effective procedure for weight loss. The big conflict between Rutledge and American bariatric surgeon is shown through the conferences in the United States. And Rutledge was struggling to convince American surgeon about his procedure. So American Society of Metabolic and Bariatric Surgery, it didn't accept Rutledge procedure. And it has been just rejected in the United States. The British Obesity and Metabolic Surgery Society in the United Kingdom accepted the procedure, but they put a condition: to start doing MGB, you have to go through a very, very complex process. I'll explain to you later on. Then Diabetic Society Summit, Diabetic Surgery Summit, the second one held in London, which I attended, and Professor Robino was the organizer. He's Professor of Metabolic Surgery, King's College Hospital, did not recognize MGB or one anastomosis gastric bypass as surgical treatment of type 2 diabetes, but they accepted adjustable gastric band as a procedure, which is a joke in scientific talk. And then reflecting on our data in the United Kingdom, I'm presenting the last audit published on BOM's website. We have about 7% revisions of all bariatric surgeries. We have mortality 1.7 in 1,000 patients, which is one of the lowest mortality after this complex surgery. The average admission to the hospital is 2.6 days. The most important for patients is excess weight loss and resolution of morbidity, comorbidities after bariatric surgery. So excess weight loss is 58%. And especially the best outcome after Roux-en-Y gastric bypass, 68%. But for diabetes, type 2 diabetes resolution is about 50%. Very short term study, follow-up studies about 2 to 3 years. This is the famous study in bariatric and academics and surgery. This is SOSA study, Swedish object-subject study, obesity subject study. They got 10 years follow-up of their data. But as a scientific and academic, we should interpret their data cautiously. Why? Because only 19% of bariatric surgeries, including in this study, are Roux-en-Y gastric bypass. Majority are vertical banded gastroplasty, which has a banded procedure, and the rest is adjustable gastric band. You can see the most success rate is 25% after Roux-en-Y gastric bypass. Not that great, actually. But the majority of the success is a short-term success. So it's about 2 years follow-up. Type 2 diabetes resolution is 72%. But as you go with the long follow-up, then the resolution of diabetes 30.4%, for reasons we can discuss later on. The question is, as a bariatric community, we are committed to produce the best possible treatment for our patients. Are we happy with our results? The big question or reflection, do we need a change? And that's why we are looking for a new procedure. And we can't accept our results if we do the same thing. We can't expect changes. If we do the same thing again and again and again every day, we shouldn't assume any difference in our results. So we have to really look for changes. And any progress in this life, whether it is science, whether it is medicine, anything, is not possible without change. We have to change. And that's why I ask myself, as a Roux-en-Y surgeon, I've been involved in 2,200 procedures over 9 years. Do we need a change or not? But the change in the UK is really dangerous, risky, and you just get one patient wrong or a mistake in one patient, you are gone. It's not easy thing to do. The challenges I faced when I changed from Roux-en-Y to MGB is the learning curve, the morbidity of the patients, the mortality. The local institutional policy is horrendous, very bureaucratic system. There is very strict clinical governance system as well. The new procedure introduction needs approval locally. You have to arrange the theater staff issues. Instruments, you get the correct instruments to help you doing your operation. Communication, to explain to the patients, because patients in the UK, they are very educated. They go to the online and on the internet, they watch the operation on YouTube, and they come bombard you with many questions. And as a bariatric surgeon, you have to be ready to answer all these questions. And CCG agreements, the clinical commissioning groups agreement. The United Kingdom system has changed. 30 years ago, the power in hands of surgeons or physicians. Now the power in hands of GPs, general practitioners. Department of Health transfer money to general practitioners, and they decide which patients they refer to us to operate. So start a new procedure in the UK, it's just like you are playing with tigers. And you have to be just like this, little monkey, to be successful. So it is timing, it is a skillful movement, it is your experience that's defend yourself. It's not easy things to start. So I believe MGB is good operation. So what is the evidence to present? We have evidence from meta-analysis and systematic review, which is the strongest evidence in supporting scientific findings and research. We have randomized controlled trials supporting MGB, and we have comparative study and retrospective study. Professor Lee et al. Is his famous study in obesity surgery, which is the official journals of International Federation of Obesity. After reviewing about 7,150 operations, he concluded the following outcomes. So type 2 diabetes resolution is 90.6%. For the first time, as a surgeons, we are speaking about a cure for diabetes. His excess weight loss from this study is about 74.9%. And the mortality is 0.14%. is lowest than any general surgical procedures. So we are proud of these results. Professor Lee concluded MGB, or single anastomosis gastric bypass, is a simpler and safer alternative to Roux-en-Y gastric bypass, which is more complex procedure. Most importantly, recently published meta-analysis, which is comparing Roux-en-Y gastric bypass, sleeve gastrectomy to MGB. This study is published by Guan et al. And is clearly shown the superiority of MGB when we consider excess weight loss, type 2 diabetes resolution, and operative time. Just to show you quickly the randomized trial of MGB. So many randomized trials, but I selected this smaller groups of randomized trial. The phase 1 is comparing laparoscopic sleeve gastrectomy versus single anastomosis gastric bypass. And again, is single anastomosis gastric bypass is better glycemic control than sleeve gastrectomy and higher incretin level. So it's more successful. Another randomized trials is comparing laparoscopic sleeve gastrectomy versus one anastomosis gastric bypass. And again, there was no significant difference between laparoscopic sleeve gastrectomy in outcome after 1 year of excess weight loss, remission of hypertension or quality. But MGB has marginally better outcome for type 2 diabetes. But the author were not able to conclude firm results from this study, and they suggested longer follow-up is needed. Another study comparing laparoscopic gastric application from Iran, actually, to MGB. And they concluded both procedures are effective for excess weight loss. And we know Iran has very good experience with laparoscopic gastric application. And they put it in the cost effectiveness, because you're not going to use a stable or anything in gastric application, you just underrun with suture. So of course, it will be cost effective procedure compared to MGB. And then in the Annals of Surgery, the American journal with impact factor of 7, very good journal, Professor Lee reported a randomized trial comparing Roux-en-Y gastric bypass and mini gastric bypass. And he concluded that mini gastric bypass is a simpler and safer procedure and has no disadvantages at all compared to Roux-en-Y gastric bypass with follow-up of 2 years. There is currently a very big randomized controlled trial from Switzerland, and they are looking for different parameters after this procedure, including type 2 diabetes, resolution, and the excess weight loss. Recent study just published 2018 in surgical endoscopy, and they have 15 years experience with MGBs. It's about 1,700 morbidly obese patients. Major complication is 1.7%, slightly higher than what Lee's study, the meta-analysis, showed. Revision rate of 4% is better than UK, actually, data. And mean BMI after the follow-up is 27. So actually very good results. This is 15 years follow-up. What is MGB? One anastomosis gastric bypass. My bariatric surgeon colleagues, they know that. There are end-to-side, side-to-side anastomosis. Basically, by Rutledge definition, is very long gastric pouch, is 12 to 14 centimeters, and end-to-side anastomosis of biliopancreatic limb of 200 centimeters. This is in short description. And you can consider it is a form of gastric bypass, a new form of gastric bypass. But it is with better outcome. So there are new features in these procedures make it attractive to bariatric community. I'll just to show you quickly the technique. This is stitches to mark the 200 centimeter from DJ junction. And then start stapling the stomach up to the gastroesophageal junction. I should be very careful at the esophagogastric junction. So to keep yourself away. Create stapling the gastrojejunostomy and close the enterotomy. It's easy operation, very simple, but there are tricks. You have to master them. I always fix the medial side of anastomosis to the remnant stomach to prevent the rotation and kinking and obstruction, early obstruction. I also put a stitch on the lateral side to reduce the tension on the lateral side of gastrojejunostomy. But I'll show you in full video later on. Sorry, it's going to. So I'm going to present our data, 2 sites. I am very much collaborating with King's College Hospital. I work for King's College Hospital for 9 years, but currently I'm working in Doncaster. Still, I have strong tie with King's College. And the surgeon there, Mr. Shamsi Al-Hassani, who's another Iraqi surgeon there. He's a man with a gold hand, very, very experienced surgeon. Our data between 2 centers, Doncaster and King's College Hospital Center, we have done more than 400 cases. Actually, our data accepted in International Journal of Surgery is going to publish this year. We have done 400 primary MGB procedures. We have 2.5% revisions. 10% of them are for revision, so patients who had sleeve gastrectomy before or adjustable gastric band. The age group is 19 to 68, mean 44. Majority, as you know, is women, 68%. BMI is about 48%, the mean BMI. But of the largest patients we have done 78. The weight, the largest patients we have done 235 kilos, and 21% of our patients are diabetic. Obstructive sleep apnea is about 6%, and 19% are hypertensive, and 31% they got arthritis. Excess weight loss from our data is 76%. Is excellent results actually comparing to average UK results. Diabetes, type 2 diabetes resolution within our follow-up of 2 to 3 years is 83%. This again is excellent results. Hypertension resolution 61%, and obstructive sleep apnea syndrome resolution is 100%. What about our complications? Complications of surgery is the salt of the soup. You can't have nice soup without salt. So these are all salts. Diarrhea in 2 patients, very easy. You revise it, you just shorten the biliopancreatic limb, and that's it. We have 2 liver failure in our series, 2 liver decompensation, and that's diagnosed within 6 months. Again, solution is very easy. Once you diagnose them, you shorten the limb, everything will return back to normal. Gastroduodenal bleeding, we have 1 case, anastomotic revision. We have done revision for the anastomosis. Stable line bleeding, actually this is my case, a lady who's in her 40s. She had stable line bleeding. She developed hematemesis shortly after operation. So bring her back to theater, gastroscope her on the bleeder from gastroesophageal junction, actually in the angle. I can't inject, I can't do diathermy, so the only option to go laparoscopically. And once you have done gastroscopy, then you go laparoscopically. It is a nightmare because you don't have a space. So what I have done, I just underrun the stable line. She did well. She went home after 5 days. The second complication is reflux disease. So out of 430 patients nearly, we revised only 1 patient to Roux-en-Y gastric bypass for severe bile reflux. A small bowel injury that's identified yearly, I think because it was because of rough handling of the bowel, to be honest with you. And that's repaired with simple stitch, vicryl stitch. And afferent loop syndrome, we have 3 patients. Afferent loop syndrome, we'll explain it, what is afferent loop syndrome. And that's all, is easy revision to Roux-en-Y gastric bypass. So is MGB is the Newton apple? I don't know, and I think progress is, or the time will answer this question. Is it the last operation in our series? This is the largest UK families. They got 19 children. They are preparing number 20, but they said we have run short of names. We don't have names. So is MGB is the last bariatric procedure? I'm not sure. Again, the time will answer this question. But as a bariatric surgeons, our physicians, surgeons, we are obliged to look for new tools to improve our results, to produce better outcome to our patients. And it looks odd if you are in 2018 and you use old phone, 1980s. So still, with all due respects, I go to these meetings, big meetings, and there are big names in the bariatric fields. They are sticking to the same arguments, sleeve against Roux-en-Y gastric bypass, adjustable gastric band against the sleeve or against Roux-en-Y gastric bypass. And Newcastle meetings 3 years ago, I was in big conflict with John Dixon, who is an Australian guy who's considered as the godfather of adjustable gastric band. And they are trying now collaboration between Australia and UK to do a randomized trial comparing adjustable gastric band to sleeve to Roux-en-Y gastric bypass for efficacy or to treat type 2 diabetes. It is a joke, it's a big joke, and it was really hot discussion in Newcastle 3 years ago. I believe MGB is a good procedure in the correct way forward to produce better results for our patient, to reduce the risk to our patients. These patients, they have no big, strong physiological reserve. So they are critical, they are just on the verge. And the last thing, as a bariatric surgeon, you want is to bring them and to give them complications. So in the UK, as a part of what we call it clinical audit, is effectiveness. You have to choose the correct patients in correct time, and you give them correct operations to get the best possible outcome. Sometimes you need to prove yourself correct. You just present your result and results will speak about you. Just in short conclusion, I believe MGB, one anastomosis gastric bypass, is providing acceptable results for metabolic syndrome. It's not only from evidence from scientific research everywhere done internationally, but it's on national level as well in the UK. I am leading the UK MGB project, and so far I have received data of 900 patients. I'm still waiting for 2 centers to send their data. That's going to be about 1,700 patients. We are going to present this in a Spain meeting in June. And I believe Professor Pazorki possibly can attend this meeting. It's a very good meeting, MGB meeting. We can present our data. So it is acceptable results for metabolic syndrome, weight problem. You can easily correct your morbidity after this procedure, the complications. And what we want, there is no mortality at all. So this is the most important, not only in the UK, in Iran, everywhere, in Iraq, everywhere. You don't, it is very important not to have mortality. Thank you very much.
Thank you, Professor Abdel, for your nice and informative presentation about your experience in changing from Rowan to MGB. Shall we have the space for open for any questions for the Professor Abdel? Yes. Yes.
Thank you very much, Dr. Abdel, for a very nice and interesting presentation, informative. And you really satisfy us with the story of developing such procedures and molecules. Although the MGB is simple and one anastomosis procedure can be revised and reversed at any time, but still there is a controversy about efficacy and long-term outcome with the sleeve. And to my information, I don't know exactly, there is a recent Croatian surgeon, bariatric surgeon, who combined both between the sleeve and the MGB, a new procedure, to overcome the rest of the remaining 20% of the weight reduction and the maybe 10 or 15% of the hypertension and other comorbidities. Do you have any idea about this?
Honestly, I didn't come across this new modifications of MGB, but I know there are surgeons who are putting bands over the long, slender pouch as well. There are lots of talk about the techniques. Everybody is doing it differently. Rutledge technique is different from Carbajo technique. There are people over all the world, in America and in Asia, they are doing it in different way. Different way in using different size of bougies, different way in the length of the pouch itself. You go and you see these videos in the meeting, and the gastric pouch is less than 6 centimeters. This is not MGB. You go and you see videos, dissection of the gastroesophageal junction, repair of hiatus hernia. This is not MGB, all right? So somebody has combined a sleeve with MGB in one procedure. I didn't see this video, honestly. But I think it is a search for the best operation. And this is the beautiful thing about science and about progression. You have to search new ideas and new methodology. Unfortunately, in the UK, we have very bureaucratic system in research, and the guidelines are very strict. So it is not easy to introduce any new modifications on a human being. It has to go on possibly animal models study for a certain period of time to prove its efficacy, and then you start doing it on human beings. I am sitting also in National Research Ethics Committee, UK. I am a member, so I know the process. It's very complex. It is not easy things to do. And that's why all recent innovation in the surgery is hardly coming from the UK because of this very strict system. I can give example, the face knots procedure, natural orifice transluminal endoscopic surgery, it comes from India because they are soft. They have lax system of clinical governance, and you can't do anything actually. It is counterproductive because you don't want to harm your patients in one arm. At the same time, you want to progress. So this is the balance. And the UK is a difficult one at the moment. But I would support any new idea to improve results, whether it is MGB or not a classic form of MGB. Yes.
Thank you very much for your informative lecture session. Actually, I have two questions. First of all, in comparing with the sleep gastrectomy, what about the greening hormone secretion? Because in sleep gastrectomy, you are going to remove the source of greening hormone. Now you are going to keep it. Oh, it's already, there's no cut-off. The second question, in non-limb bypass, or one anastomosis gastric bypass, what about dumping syndrome? That's the second. Thank you very much.
Sorry. So MGB, I'm going to talk about this in details in the second tomorrow. I'm going to present the hormonal changes after MGB, sleeve gastrectomy, and Roux-en-Y gastric bypass. But basically, MGB is a form of gastric bypass. So the changes after one anastomosis or mini gastric bypass, it is mirroring the changes in Roux-en-Y gastric bypass in some aspects, but not in all. In terms of the second question, the MGB, so the length of biliopancreatic limb is quite different from patients to patients, actually. We have certain criteria to choose which length you are going to give to which patients. Our local policy is any patients whose BMI between 40 and 50, I give them 150 centimeters of biliopancreatic limb. Any patients above 50 BMI, I'll give them 200 centimeters biliopancreatic limbs. Why? For two reasons. The first reason is evidence from research has shown if you go above 200 centimeters biliopancreatic limb, then you ask for trouble in about 1 to 2% of patients. They will develop liver failure, hyperproteinemia, and chronic diarrhea. You don't want this in the UK, all right? So we are working in very difficult health system. That's number one. Number two, we are giving them bit what we call it conservative approach. So you are not aggressive with them. I know Miguel Carbajo, I met him and he is doing 2.5 to 3 meters in Spain. But the health system in Spain is quite different from the UK. So it's a bit, you are sit back rather than to go forward. You don't have any trouble in the UK. It's a really difficult system to work, and it's my experience with 13 years now. So we are just playing it safely. We go with mild procedure and then you increase it as the patient's in need. Rutledge Wards, I met him in Napoli, September last year, an MGB meeting, and his word is the biliopancreatic limb is the monster of the procedure. So you talk to the patients, BMI 78, you don't give them 150 centimeter biliopancreatic limb. You give them 300 centimeters of biliopancreatic limb to produce the maximum effect. And then you talk next day to a patient's BMI 40, you don't give them 300 centimeters, you give them 150. So you have to balance it yourself actually. But for the patients who you give them very long biliopancreatic limb, you explain to them, look, I'm going to give you the monster, it's going to control you, but I'll bring you in 6 months' time to revise it to shorten the limb. Revision, as Professor Ali said, is very simple. You just dismantle the gastrojejunostomy, you move the junction from this side proximally to 150 centimeters. Having said that, the measurement of the limb is a big conflict and argument in meeting. How are you going to measure the limb? There are studies, as Professor Bazorki knows in the literatures, that if you have 3 surgeons measuring the same limb in the same patients, every surgeon will end up with different results. Why? Because measurement of the limb is not accurate by any means. For different reasons. How are you going to handle the bowel? Is it stretch? Is it lax stage? Patients fasting or not? There is sympathetic tone playing role as well. More than this, we know from Gray's anatomy the length of a small bowel is different. So it's 4 to 8 meters. Which patients you are going to give 300 centimeters, which patients you are going to give 150 centimeters. If that patient's got a small intestine of 800 centimeters, giving them 150 centimeters is not going to work effectively. Possibly they will lose 20% or 30% of their weight, but possibly they are going to fail. So there are a school as well among MGB surgeons that we have to measure the common channel from the gastrojejunostomy to ileocecal valve. And it is just like Professor Torres from Spain. His SADIS procedure is another bariatric procedures. And he used to measure from the ileoduodenal anastomosis to ileocecal valve to give the patients about 200 to 150 centimeters. Again, it depends on the BMI and the diabetes. I'll stop here. The talk is too long because we have a program. I don't want to disturb the program.
So because of the shortage of the time, we have to go to the next session. We may have only one question. I think the other questions will be on the next session.
Assalamualaikum. Salam.
I'm far away from the center, but I faced 3 cases of bariatric surgery done for them. 2 of patients died because of toxic carbonadasty, and 1 had a chance to live because of rupture.
If I tell you about our team, it's a huge team. We are supported by very strong infrastructure. So yes, as a surgeon, you are doing the operation. Complications, as I said, it is happening to everyone, no one immune. I can tell you our figures of Roux-en-Y gastric bypass. We lost 2 patients We have done about 2,200 patients. 2 patients died. So mortality is there even within the strong infrastructure, still patients could die. And if you have read about the bariatric surgery mortality score, the mortality could reach 7%. So the mortality is a possibility. Unfortunately, you can't prevent it sometimes. It happened in good hands, big names in bariatric surgery. If I tell you a story from the UK, you will be surprised. Big names, they are losing patients, more than me or my colleague in London. So still patients could die. But interestingly, bariatric surgery mortality is lower than any other general surgery procedure. Take, for example, colorectal surgery. What is the mortality in the UK? The leak after colorectal surgery and ileocholic anastomosis could reach 5 to 8%. I can tell you locally from my hospital, within 6 months, 3 leaks by colorectal surgeons, and 2 of them died. Age of 50, died, coming for cancer surgery leak, sepsis. As you correctly said, delayed diagnosis in some of the cases. So this is the trick of whether it is bariatric surgery, colorectal, whatever kind of a procedure. When you have your complications, you jump and sort it out. You don't wait. Well, we do blood tests, see inshallah tomorrow. It's not going to work, unfortunately. When you have a problem, you jump and correct it. And this is the secret of success. So this is my answer to you. Unfortunately, I feel sorry for these 3 patients. But my experience with my colleague in the UK, no one immune from complications. Not only in the UK, I've seen big name professor in Düsseldorf. This is just by the way. I was there 2003 for vascular training in Düsseldorf. And the professor, he brought a patient, 37 years old, common carotid aneurysm, Marfan syndrome. He resected the aneurysm, put a clamps, exclusion clamp on arch of the aorta, and he did the anastomosis, 30 minutes job in his hand, okay? Released the clamps, blood everywhere, immediate dissection of the aorta, heart-lung machine. Patients died on the table, 37 years old. In Germany, base center in Germany, in Düsseldorf, they published the largest study in the world of repairing type 2 aortic, thoracoabdominal aortic aneurysm. It happened. Unfortunately, there is a learning curve for bariatric surgery, and every procedure has got learning curve. But you have to have the good infrastructure to start it in the first place. Thank you very much.